I have some very bad news here. Extremely bad news. Actually, there's two pieces of bad news. I'm going to try to, I haven't started learning PowerPoint software or Excel, so I hope you can bear with me. This is the publication that's causing so much concern. This came out of Germany. There was also an autopsy study that came out of Germany around the same time. It's reporting a lot of heart damage, and people had relatively mild cases of the COVID-19. And they're seeing if you go through the study, they were pretty careful in who they selected. They went through a database from the hospitals. People had been identified by the right testing that they were positive for COVID-19, and then they had recovered. Patients recently recovered from COVID-19 referred for a clinical CMR due to active cardiac symptoms were not included in the analysis. So they've excluded people that were not normotensive. They had regular, if you didn't have regular blood pressure, you were excluded. So they excluded some of the people in the higher risk. So when they came out with 78 out of 100 had signs of cardiac damage, that's a pretty high number. I think it was around 60 to 90 days after the initial diagnosis of the disease. So then a few days later, that was I think that was on July 27th. On July 29th, this group did a review, and they talked to the lead investigator that had submitted the publication, and they also, because there was some controversy about a few things, it was 64 to 92 days after. They talked to his fellow Carr, James Carr. He's the president of the Society for Cardiovascular Magnetic Resonance, who said he was aware of the questions raised. The questions were about something about the statistical method with the mean and whether the picture they used was the exact picture according to some of the records. Now here's what this fellow Carr has to say. He says, there is clearly an impact going on in the heart, and I think that's probably indisputable. And he agrees with the protocol that was utilized. It should be a combination of the basic protocol, which is scene imaging and late gadolinium enhancement plus T1 mapping and T2 mapping, Carr said. And so anyway, I think with, they talked to the lead investigator, Puntmann, Valentina Puntmann, PhD, MD. And she was aware of these questions, and they're looking into them. So anyway, this is what I consider so far the most valuable review of the study. There was another one that showed up in on the same day in Stat. You can get a free their free newsletter. It's excellent. This one was written by Elizabeth Cooney. The question now is how long these changes persist. they're talking to Matthew Tomey, a cardiologist. Are these going to become chronic effects upon the heart, or are these, we hope, temporary effects on cardiac function that will gradually improve over time? So we just don't know yet. There's not enough information. Now, we've been saying there have been reports, autopsy reports for several months about damage to different parts of the body, including the brain, the kidney, the heart, the lungs. And Dr. Seult, Seheult at MedCram, he's reviewed some of those autopsy reports. He does excellent reports, maybe 3 or 4 days a week. He works in San Bernardino County in California, and I think in 2 clinics. He works with people in the ICU, and then somehow he finds time to search the literature and report to us, what's of high relevance. Now, the other place I saw these studies reported was in ZME Science. And this is one of the reports. Now, there was also a report of autopsy that came out of Germany around the same period of time. In this analysis of autopsy cases, viral presence within the myocardium could be documented. Okay, so this is the autopsy report. Now, here's where the reason why I'm doing this versus just citing or referring, saying here's the experts, is that just by serendipity, I've been trying to work on some elevated prostate cancer risk markers. I've actually been working on that for 6 or 7 years. And it turns out that 2 of the markers that I am utilizing have strong evidence to help with heart failure risk. That's the galectin-3 and the SII, Systemic Inflammation Index. So I've got the evidence here on the SII and the galectin-3. Galectin-3 has been approved by the FDA as a marker of heart failure risk. Now, we're specifically staying focused on heart failure versus things like plaque buildup, because they're different. Of course, there's a lot of overlap, things that we can do, for both the plaque buildup or the heart failure often help both. So, now before I lose track of the other bad news, is that the rapid decay of our antibodies. 2 publications on that our immunity is not nearly as long as with the MERS or the SARS-1, a half-life of approximately 73 days. We found antibody loss that was quicker than that reported for SARS-CoV-1, and our findings were more consistent with those of Long et al. So this was the most recent. I think this was late July. And then here's the one that they cited, that they referred to. This came out of China. And it's basically, this was 4th of June. Okay. So now, I'll get back to the galectin-3 and the SII in a minute, but there were, I'd invested heart failure risk a couple years ago, and I noted that there's a heart failure epidemic in the United States. So there are 2 of the things that I found that looked at are with extremely minimum side effects and well documented systematic reviews, meta-analyses. I even found one of them, I found a systematic review of systematic reviews. Now, systematic reviews and meta-analyses, everybody that goes to medical school, and incidentally, I'm not a doctor. I have some background in basic research. They're taught to use meta-analyses and systematic reviews, to see what the experts are saying about a specific disease. So here's the one that's the systematic review. This is for CoQ10. Now, it's been used since 1974. It was approved in Japan. The clinical benefits of CoQ10 supplementation in prevention and treatment of heart failure have been observed in many trials. And they list 5 trials. And Japan approved it in 1974. Okay. So CoQ10, front burner item to investigate, look into. Now the other one is hawthorn. Hawthorn has been used since the 1890s for congestive heart failure in the United States. And it benefits our health, and especially cardio health, in, 8 or 10 different ways. They're all pretty technical terms. I didn't highlight. Oh, yeah, I did. No, I'm not going to read that. It's too long. It's too technical. But it says recommended dosages range from 160 to 1,800 milligrams per day in 2 or 3 divided days. I think they meant doses. There were no reports of drug interactions. That's very helpful. No reports of drug interactions. Side effects, very minimal. So here's the report on the hawthorn. So that's another front burner item. Like I said, I'm not a doctor. I'm just giving my assessment of the literature. If people want to try different herbal supplements, I highly recommend find a functional medicine doctor. There's a website you can punch in your zip code, or a certified naturopath and if you're going to go ahead and try them, try them at a very, very low dose to make sure you don't have a sensitivity or an allergy. Right now, I've tried probably 200 herbs over the last 30, 40 years, and I have had once I got really bad cramps from a Southwestern plant. They were selling it. I won't mention the name of the company, but I got really bad cramps. I also get super bad cramps from doxycycline. So I had to call a doctor about that once. He said, well, that happens in about 1% of patients. So they had to use something else for infection. So now I want to get back to the galectin-3 and the SII as markers. Right? Now the galectin-3 is a pretty cheap test. You have to have your blood drawn. But the SII we can calculate ourselves with our CBC, our blood count, which most of us have done maybe once a year or every 2 years. We multiply the neutrophils by the platelets, and then we divide that by the lymphocytes. And then that'll give us a number. And then these publications, I'm going to mostly just show the title. They tell us what number is a indication of heart failure risk or heart failure death. I did write down some specific numbers. Now, one is cardiac death is 694. If it's over 694, you're in an elevated risk. 551 is a heart failure risk if it's over 551. And 834 is a elevated risk of osteoporosis. And frequently, if you dig into the literature, they give a high hazard ratio, they'll give a p-value, and so you can determine how reliable this is. And for those people without a science background, these are just markers. These aren't cause and effect. It's kind of like cholesterol is brought to the site of injury, to the artery lining, to help repair it. It's damaged. It's kind of like you see a fire truck at a fire. and then saying, well, every time I see a fire, there's a fire truck there, so the fire truck isn't. Well, no, not necessarily. The cholesterol is not necessarily helpful in determining risk of plaque buildup in our arteries. Okay, so now to here's galectin-3 predicts new onset heart failure, systematic review and meta-analysis of prospective studies. This is from 2018. Okay, this is correlation between galectin-3 and adverse outcomes in myocardial infarction patients, a meta-analysis. This is from 2020. Okay, soluble galectin-3 is associated with premature myocardial infarction. This is from 2016. Prognostic value of systemic, this is where I'm going to get into the SII, the systemic inflammation index. Prognostic value of systemic immune inflammation index in patients with chronic heart failure. Now this was Kaplan-Meier analysis revealed that patients with high SII greater than 551 had a significantly greater risk of cardiac event, 85% versus 36%. P-value 0.0001. Adjusted HR 3.34. So here's the back side of that paper. Okay, here's systemic immune inflammation index predicted clinical outcome in patients with coronary artery disease. This is from 2020. Okay, this is for osteoporosis and systemic inflammation. This is where I first read about this. I've been looking into this SII for probably 6 or 9 months. So, now there's other markers. The reason I was following these markers, like I said, was because of prostate cancer risk. Not because I have it, but my markers were going up, and I'm not going to wait. I want to act now. 50% of American men wind up with cancer. I think about 30% of women, and I think I saw something on the news about 15 minutes ago that 1 out of 5 children get cancer. And this is really relates to all these things are interrelated. There were reports early in the last century where doctors would go from major cities in the Western world, from Paris, from London. They would move to a little village out in the country in Africa. And they were used to seeing cancer, perhaps 5 or 10 cases a month, just roughly. I don't know. Whereas this little village they had very little contact with the food from the city, they weren't seeing that many cases in a year, So my approach to all this was prevention. It's kind of like preventing Alzheimer's. There's a lot of things we can do to prevent Alzheimer's. There's a lot of things we can do to prevent heart disease. I punched a bunch of my markers into a heart risk calculator. There's about 4 or 5 of them online. They're all designed by these professors and scientists. And this one accepted CAC, your calcification, and it accepted things like triglycerides, HDL, and after working hard for 4 or 5 years, my risk of a heart attack in the next 10 years is 1.6%. I think when a cardiologist used the Framingham method, I think it was around 3%. So this is another reason why I'm doing this video. These interventions that I'm utilizing based on the science, they're working. My main markers are prostate cancer risk, which are actually the percent free the LMR, the lymphocyte monocyte ratio, they've been coming down. So I'm starting to relax a little bit. Instead of being in a 20 to 30% risk of prostate cancer in the future, it's improving. Now here's the one that really got me interested in lymphocyte monocyte ratio. And this was reported on by Dr. Fahey. Dr. Fahey published almost a year ago. It's the first publication demonstrating age reversal. Dr. Fahey and Horvath. Horvath is involved in the utilizing a bunch of methylation DNA facts to determine our actual biological age, not our chronological age, our biological age. So Horvath was involved in that. And Dr. Fahey, what they found was that while they were doing this, they were trying to improve the thymus gland, which is intimately involved in our immune system. And this fits into our immune system. That's the other thing, the other cornerstone of this presentation by me is to improve our immune system function. So they found that, and they were successful. They were doing MRIs of the thymus gland on people. This wasn't in animals. And the fat diminished substantially. So, Dr. Fahey's a really interesting character. When he does a presentation, he'll say things like, well, and after he's presented most of my best guess on this, or he'll say, this is pure speculation. And that's really neat because he knows we want to know everything that he thinks about this. Age reversal or slowing down aging. I mean, he studies this, day in, day out. So they found that a bunch of the markers for prostate cancer risk, like LMR, the average went up above 5.0. And PSA, these things improved substantially as a result of this intervention with utilizing growth hormone, metformin, and DHEA, and I think a couple of the minerals. I forget what they were. I think they were zinc. But I think they were using the metformin and DHEA because with growth hormone, there's often a worsening of diabetes. So they were trying to keep a handle on that, which they did. But this is really valuable information to have this. Now, that wasn't the first age reversal. There was another age reversal publication after that. Horvath was involved again in that, so it's easy for people to find. But that was using some kind of parts of blood. And they'll probably never reveal the exact compounds in the blood. Who knows, they may. They're going to have a product on the market. They're going to call it, I forget. Let me get into that. But the reason I'm bringing a lot of these things up is because a lot of this, it's interconnected. Now, the other thing that I want to make sure to highlight is the damage of the omega-6 oils at a very fundamental level, where they're very unstable. We can detoxify to a certain extent, but they're also involved a lot in signaling in the mitochondria. They may not, I'm not even sure that we use them a lot for actual energy. But here, this is a really good one related to the, this is the cardiac dysfunction. Induction of mitochondrial nitrative damage. This was 2006. And then here's this is about soybean oil. And that's got a lot of that linoleic acid, which our body can only, like I said, we can only detoxify so much. We're going outside the range of our evolutionary familiarity. We're just, if we're getting, I think it's up to as much as like 29% of our calories from these highly inflammatory. They cause a lot of inflammation. And then causing inflammation, they're upsetting the signaling for our appetite and our satiety. So we're not getting the proper signals that we've eaten enough and we don't need to eat more for maybe 24 hours or 30 hours. We're hungry all the time. So now as far as, here's another thing, I want to make sure I don't miss this. This is about the dietary changes to make to improve our heart function, reduce our cancer risk. Now, this is arguably the most useful heart disease diet-related document I've seen. Now, they're also making use of 3 supplements, DHEA fish oil, 200 milligrams of grapeseed extract, and 50 milligrams of pycnogenol. But this is this doctor collected data every 3 months. He collects this doctor's pretty neat. He accepts Medicare and Medicaid, and the majority of his patients speak English as a second language. His clinics are open on Saturday and Sunday, and he feels like he's going to do this till he dies. This is what he does. This is his, Now, it also happens that this particular doctor had done, him and a partner, he's a cardiologist that does a lot of heart surgery. At one point, he had done the most heart transplants on infants in the world. They may still have, so he's got a lot of experience and background with heart problems. So he's collecting data on 978 patients over a period of, from 1.5 to 12 years. The mean is 9 years. And 978 pages, age 42 to 89 years old, with known CAD. Defined as previous MI, stent, CABG, or positive stress test, positive core score greater than 30. So this value, the recurrence rate normally at a 5-year interval is about 30 to 40%. Well, with this intervention, the recurrence rate was 1.6%. And one more little fact about Dr. Gundry, he changed his practice dramatically, I think around 18 to 20 years ago, because of one of his patients. He told the patient he couldn't operate him because the blockage was 90%. And 6 months later, the patient came back. His nickname is Big Ed. My name's Ed too. And I'm pretty tall. I used to be 6'4", but I've shrunk 2 inches. But I feel pretty good. But anyway, he came back 6 months later. He said he'd been taking all these supplements. And come on, just check it again. See, maybe now you can do the, do the heart surgery, And I'm not sure if Dr. Gundry told him he was just creating expensive urine, but then he finally persuaded him. So Dr. Gundry did another, I think they call it an angiogram, where they examined for the exact amount of blockage, and it had gone down by 50%. And Dr. Gundry was absolutely astonished. He'd never seen anything like this. So he did do the surgery. But now, today, he says that if he had to do that over seeing all the recovery of so many of these patients where the plaque buildup is often diminishing, it's getting less. He wouldn't do that surgery again. So anyway, that gets back to other ways to improve our heart health. Now, the last thing here that I want to review, I hope I can get this to show up. I'm not sure if it's just going to show up. Well, I'm going to have to start learning how to use Excel. I collected my own data on 6 markers. And I bought some graph paper and graphed it out. The SII has gone down by like 30, 40%. The LMR has gone up, and that's good. The percent free is staying pretty much the same. The NLR diminished quite a bit. That's the neutrophil lymphocyte ratio. The galectin-3 had gone up 3 times since I started using the modified citrus pectin in January. I started the modified citrus pectin 10 days before the test. And I'd had my other things tested about a month before that, like the LMR, the things like you can calculate yourself. So when I got this tested, these other markers had improved a lot from a month before. The LMR, the PSA had improved some. It had been 6.2, went down to 6.0. And so I was using the dosage recommended by Isaac Elias. He has a prostate cancer medical practice in California. And I had ignored his work for quite a while because he sells things. So I just, you only have so much time. I said, oh, he's selling all these things. There's a conflict of interest. And then finally I got around to examining his prostate cancer prevention formula, which has 30 herbs in it. Well, as I looked at it closely, went over each herb, I realized at the time I was taking 29 of them. And I'm pretty careful about things having side effects, preferably having a long history of use, and good research that it's got a potential to help. So that's when I started to look into his, and he has some products, but and his name's on a lot of the publications. But the modified citrus pectin combined with hinokiol at a 9-to-1 ratio, with the hinokiol being the less. So I saw these markers improved, had it tested a month later. Fortunately, I'm seeing 2 doctors that are cooperating with me on this. And the markers got worse. Well, I had cut back on the dosage of the modified citrus pectin I think he recommends 15 grams for 3 days, and then back to a maintenance dose of 10 grams or 5 grams a day, depending on your level of galectin-3. I think if it's over 9 or if it's over 12, and then I think the really danger zone is when it gets up over 17.8. So mine, over the next 3 months, my galectin-3 had gone from like around roughly 9 to 10 to 11. It was getting worse. And then all of a sudden, not all of a sudden, after 2 months, and I started making a liposomal formula of the modified citrus pectin to cut down on expense. My budget's, I'm right up against what I can afford with my budget, and it dropped to 8.6. That's over a 20% drop in 2 months. So I'm starting, so the SII has been improving, the LMR has been improving, the galectin-3 has been improving, the PSA has been improving. So now there's one other interesting thing about the modified citrus pectin. When I started using it as a liposomal formula, and this is very easy to do. It's not even really chemistry. There's a lot of videos online. When I started getting this slight nausea feeling, maybe 10 minutes after drinking it. Not severe, kind of like when you get a mild cold or mild flu, or you just feel like laying down. And then I started noticing that if I took a little extra of the prostate cancer prevention formula with over 30 herbs in it, I didn't get that feeling. Now, that particular formula has a lot of berberine in it. I'm putting like 6 grams in there. I use it, it stretches out over 2 weeks. So 6 grams isn't really a lot on a daily basis. But, so I increased the amount of that I take by maybe 1/5 or 1/4. And then I don't get that draggy feeling where I want to lay down. Now, once again, this isn't medical advice. I'm just sharing things that I think are relevant to this situation we're in, where, they're finding all this heart damage, and they're also finding that the duration of the immunity, this is going to upset a lot of the these herd immunity hypotheses, So I think that's about it for now. Thank you for listening.